I'd like to introduce Evan Alexandrou, who is a senior lecturer at the School of Nursing at the Western Sydney University, but also runs in his spare time the Central Venous Access and Parenteral Nutrition service at Liverpool Hospital, which is one of the longest running nurse-led central line insertion service in New South Wales. So thanks for leading us there, Evan, and your ex-partner in crime, young Tim. Evan led the OMG study, which was a massive, big international study, which has got some great data in it. So Evan should be congratulated on that really wonderful study. So Evan's first talk is going to be something we'd had a little talk about before, and that's getting the right device in the right patient. Evan.
Thank you for the invitation to Kay and Avatar, and also thank you for giving me a lectern that I can actually see over, because normally... okay, so we're going to talk about pretty much what was resonating in a lot of the table discussions, and that's about the right device for the right patient. So when we think about it, about 80% of all patients that come to hospital will have some type of vascular access device. Predominantly, however, from admission, they're usually a short PIVC. Whether that's the most appropriate device or not, I guess can be debated, and we know from the chats that we have, well, potentially it's not the most appropriate device. But the important thing is, in terms of vascular access, it crosses all disciplines and specialties. And it's needed for hydration, for blood products, for the administration of intravenous antibiotics, and potentially regular blood sampling as well. And it is typically the first invasive device that's inserted when a patient presents to hospital, whether that's through the emergency department or even in a, if they're coming in as an elective patient having a, some type of day surgery. Access to the venous system for sedation is usually the first thing that's undertaken. But as Claire pointed out or alluded to earlier on in her introduction, cannulas have got a underappreciated failure rate, and reports in the literature go from 60 to 90% of cannulas are prematurely removed before the end of therapy. Now, typically what that means is that, if the patient requires ongoing IV therapy, it typically triggers the insertion of another device. Now, as clinicians, because they're so common, we, whether it's medical or nursing, we don't seem to appreciate the fact that there's a patient at the end, at the other end of that needle that's getting poked and prodded. And potentially it could lead to catheter-associated bloodstream infection, thrombosis, and many other issues related to insertion and ongoing care of these devices. And these complications can include phlebitis, whether that's because we haven't stabilize the device properly, it's pistoning in the vessel through the skin, causing mechanical phlebitis. It could be what we're actually giving through the cannula. It could be a little bit acidic, it could be too concentrated, or the qualities of that drug are causing irritation of the vessel wall, causing that phlebitis, or in fact it could also be infective. Of course, the other thing is the cannula can protrude through the vessel wall and cause infiltration, so that infusate that's going through the cannula then seeps into the tissue. Depending on what that is, of course, that can also lead to extravasation where there's tissue damage around that cannula site. Of course, they can block, and they can also fall out. Importantly, when we talk about infection with cannulas, which is approximately 1 in every 1,000 cannulas becomes infected, which, when you think about it, considering the volume that are inserted, it's again an underappreciated issue. Whether it's from a mechanical component or a chemical component, if we instigate that inflammatory response, a component of that inflammatory response is thrombus or clot formation, which can then also lead to colonization and infection. So there's essentially a link. If we're causing inflammation of these blood vessels, potentially there is a risk that device or that area can become infected. And this is, I guess, when we talk about the right device, it's really about a lack of experience of what is the best device of choice. And typically what happens is the PIVC is the default device for most people. They're not too sure, they'll put in that device and they'll start using it without really thinking about the ramifications of what can happen if we remain using PIVCs. When we think about what is the best device for that patient, there's a few things that we need to be thinking about. And typically, we need to be thinking about, well, what are we going to give through it? Does it have a divergent pH? Is it too acid or too alkaline? Now, we used to have parameters. A lot of the guidelines used to have parameters saying, if the pH is less than 5 or greater than 9, definitely you should, use a central vascular access device. But there's a lot more, we've got a lot more information now, so it's not just the pH, but certainly things with divergent pH will put at risk that vessel. And the reason being is it's about hemodilution. So if I put a cannula in my hand, the flow rate there is 4 mils a minute. It increases as it goes up, as the vessels become bigger and they all sort of start to join up, and the flow rate increases. It's about 150 mils a minute in my brachial veins, and by the time it gets to my superior vena cava, or the junction between the atrium and the superior vena cava, it's about 2 litres a minute. So if we're going to give something that's quite concentrated, TPN or really concentrated antibiotics, the reason we put in a central line is because as that drug comes out, the turbulent flow around that central circulation tends to mix it up and reduces the risk of irritation at the vessel wall. Even if you're using a volumetric pump, the venous system is basically a reservoir. So even if it pushes it up a certain way, it's still going to basically sort of sit there for a lot longer than it would in the central circulation. And that's where you can get that cascade of events of inflammation. Of course, if it's too concentrated, and a perfect example of that is TPN, if it's vasoactive, and I'm not just talking about vasopressors, there are antibiotics that are vasoactive. So metronidazole, Flagyl, is an example that, if given in a vessel that's too small, that can potentially cause vasoconstriction, holding that drug up even longer, causing irritation to that vessel wall. So it's about blood flow. So if we can make sure that we have adequate blood flow around that vessel, then we will hopefully limit these issues from occurring, or the issues of inflammation. So, excuse me, of all times to get a cold. So choosing the correct device is about thinking about what's going to go through that device. It's also about vessel assessment. Does this patient have visible or palpable veins? Do they have difficult access? And most guidelines and most associations will say that, if you've got 2 sites or less, then, one, you need a pretty experienced inserter to put it in to reduce the risk of failure, but they're probably more leaning towards being someone with difficult access. So thinking about the history and assessment of that patient, have they had a history of, of difficult access in the past? Do they have any clinical problems which are going to impede the use of a particular device? The length of therapy. Now, the longer that therapy is for will hopefully determine what type of device that patient will need. And of course, the training of the inserter. The more you do, the better you get. They've done studies with central venous access, where if an experienced inserter who's inserted more than 50 devices will have half the complication rate of somebody that's put in less than 50 devices. And that's pretty similar, I guess, too. If you've done lots and lots of cannulas, you're going to be a lot more proficient in putting them in compared to somebody that hasn't put in as many. So these are the factors, I guess, that will decide what type of device you will be putting in. So there have been decision tools that have been developed by various people, but primarily by industry, and they're there. And when we talk about industry, they're smart people. They've got people there working, and they also have the patient's best interest at at heart most of the time. So, you know, if they've developed these, I guess, decision tools where it provides the clinician with a bit of a, I guess, like a pathway as to what is the best device. Probably, from a clinician perspective, probably the best guidelines we currently have are the MAGIC guidelines, and they were developed in Michigan. And they're to do more with the proposed duration of the infusion. And it's estimating that if you're going to give something which is peripherally compatible, so it's not vesicant, it's not irritant, you know, if it's going to be less than 5 days, then yes, a peripheral IV catheter will suffice. If you know, if they got difficult access and you're going to use ultrasound guided, depending on where you put it, particularly if you put an area that's not of, it's not an area of flexion, for example, it can last a little bit longer. You know, and then of course, if you, depending on the type of device, if you've got a midline, in the MAGIC guidelines, so the MAGIC guidelines were developed by a group of clinicians, and they had something like 600 clinical scenarios, and they said, well, you know, this patient had is requiring IV antibiotics for the next 6 to 8 weeks. This is their clinical condition. This is the quality of their vessels. What would you suggest would be the best device? And so they got a number of clinicians all around the world, and they pulled all that together, and that's how they got these guidelines. And many hospitals now are starting to use these. So as an exemplar, I mean, we're starting to use midline catheters here in Australia a lot more predominantly. And in the MAGIC guidelines, they state that, you know, midlines are good for up to 14 days. Some of the other evidence, for example, says, you know, they're good for up to 4 to 6 weeks. So this is clinician consensus, but there have been studies that have shown that midlines, for example, can stay in for a lot longer. So what we did at Liverpool was look at, in the same vein, look at those types of clinical pathways that are available, and we developed the IV access decision tree, which is actually in policy in our hospital. So if a patient needs IV therapy, depending on the type of infusate that's required, if it's not non-vesicant, non-irritant, do they have good vascular access, how long do they need it for, and depending on the duration. For example, if it's less than 7 days, use an IV. If it's greater than 7 days, consider a midline or a PIC. If it's greater than 4 to 6 weeks, then consider either a standard PIC or a tunneled device. Probably, and then, you know, obviously if it's something that is irritant, like chemotherapy, TPN, then the patient requires a central line, expected duration, and again, that helps to give you a decision. One of the things that we did in, which is a little bit different to all others, is we also incorporated what's called the DIVA protocol. Now, DIVA stands for difficult vascular access. Like many hospitals, the burden of difficult vascular access is becoming something that we need to start to deal with. And it's not the fact that clinicians all of a sudden are no good at putting in cannulas. It's the fact that patients are getting sicker, they're more acute, they're representing to hospital, and they've probably had multiple attempts at cannulation previously. They're venous depleted, so it makes it difficult to try and cannulate, or makes a patient difficult to cannulate. Now, our after-hours CNCs at Liverpool found that they were forever being asked to try and cannulate difficult patients. So what we did was we sat down and we said, okay, well, let's try and develop some sort of system. And we actually trained our after-hours CNCs in ultrasound-guided PIVs and midlines, predominantly to use for PIVs. And we had a bit of a pathway, so, excuse me, during hours, if the patient was noted to be difficult, so they you know, so again, you know, no more than 2 failed attempts should be done. You know, if the patient was seen to be difficult, they've had a couple of goes, they couldn't get a cannula in, non-visible, non-palpable veins, the duty anaesthetist was to be called, or is to be called, and of course they're never available. So that falls to the central line service during business hours. After hours, if the ward senior is unavailable, then they contact the after-hours CNCs, who are trained up in using ultrasound-guided cannulation. Probably the biggest thing we did also was the PIVC under ultrasound, if someone's got difficult access, is really just a bridge until you can get more secure access. The biggest thing we did was that we put it in policy that that nurses, once they've discussed the situation with the medical staff, could initiate an order. So they could go onto PowerChart and they could initiate the order of a central line or a midline, or we just say just put in CVAD, and then when we assess the patient, we can make the decision as to what's the best device. And it also gives the staff a bit of an indication as to what the different types of devices are for and how long they can last for. So in the 12 months that it was running, so in 2016, we inserted over 200 midlines and CVADs for the primary reason for difficult access, and they were direct referrals from the DIVA protocol. So they were ones where the staff reviewed the patient and said, you know what, no, they've got difficult access. Let's just ring straight through and see if the central line service can put in something more secure. The true number's probably around 400, and that's really to do with the ordering process on PowerChart. And in terms of our workload, DIVA accounted for approximately 25% of our workload. So over that period, we had 379. So these are cannulas now that were inserted by the after-hours CNCs. So in a 12-month period, they inserted 379 cannulas after hours for patients that needed access, primarily in the aged care, general medical and general surgical wards. When we looked at the BMI, the average BMI was 29, so they were, I guess, on the higher side, but we also had some more sort of malnourished, I should say, patients as well. So between 14 and 80 was the range of BMI. I guess because of the way we taught the after-hours CNCs, the basilic veins were the most prominent vessels used. So they were the ones, in the bicep. And we just found, because most attempts were done in the forearm and in the hand, the brachial veins seemed to be the best that we could go where there probably wasn't going to be any thrombus there or any issues. And we used a variety of different devices as well. And they were the reasons, and primarily they were typically for IV antibiotics. Oh, okay. Jeez, gone already, bloody hell. Okay, so just quickly then, when we look at number of attempts, 92% of all cannulations were that the after-hours CNCs inserted were inserted first attempt. Only a small amount needed second attempt. Now, on the other hand, when you look at number of attempts prior to ultrasound referral, nearly 50% of patients had 3 or more attempts before ultrasound referral. And there was quite a significant proportion that had 8, 10 referrals, attempts before ultrasound referral. And when we looked at the pain score out of 10, when the patients were asked what the pain level was like, it was 2 out of 10 or less with ultrasound, compared to 7 out of 10 or more without ultrasound. So clearly, the use of ultrasound in terms of pain on its own was, was quite successful. So again, right inserter, proper training and procedural load is important. When we look at the use of vascular access specialists and vascular access teams, they're the ones that can best apply the evidence. So there is, if possible, having a vascular access team in your hospital is probably the best go. Using vein visualization devices as needed is also important. And probably one of the big things, when we look at the right inserter, globally, when we did the OMG study, so we audited 75,000 patients in over 50 countries, and we got data on about 41,000 cannulas. Everywhere in the world, 70% of nurses are the main inserters. In Australia, it's only 23%. So that's something that we need to be, thinking about. We need to start to, and here in New South Wales, we need to be thinking about more options than just HETI for, cannulation courses, because, I know at Liverpool you have to put in an expression of interest before you can even apply to do the cannulation course. Choosing the right device, and this again is talking about hemodilution around the cannula. Try and put in the smallest possible cannula in the biggest vein, not too small that it'll fall out, but not too big where it's going to occlude and cause thrombosis. And the 20 gauge in many studies has found to be the best device. No evidence in terms of how long that cannula should be, but it seems to be clinically that the longer that cannula is, the better, because it's less likely to dislodge. And 80% of PIVCs were between 20 and 24 gauge in the OMG study. So it's not too bad. I mean, most hospitals were using that size cannula. The right anatomical site, and this goes back to training, try and avoid areas of flexion. Guidelines say use the forearm, and that's what the studies have shown too. That's probably the best place to put in an IV cannula. The forearm's actually recommended by the New South Wales Health PIVC policy as well. Undertaking a proper vessel assessment. So think about where you're going to put that cannula in. Are there bifurcations, valves, etc., that are going to impede the pathway of that cannula? Also, think about chronic disease. If this patient's a renal patient, they've got elevated GFR, avoid the cephalic veins. When we looked at the OMG study, overall only 30% of cannulas were inserted in the forearm. In Australia it was 23% only, 32% were in the hand and 29% were in the cubital fossa. So, finishing up now. So using a bundle approach, and we'll go through this more in the later on in the CVC section, but basically having a bundle approach will improve your success rate and also improve your infection rates. So bundles are basically just evidence-based actions that you undertake to insert a device or undertake a clinical procedure. And here's one here that's been done by the Europeans. So indication for device selection, patient assessment, and there's a few things here you can read in the notes that I've put in there. So is it clinically indicated? Use the appropriate gauge. Consider an integrated extension set. Patient assessment. Make sure you choose the appropriate insertion site, etc. Hand hygiene. The biggest thing here is what to use, and when we look at the our antiseptic soap seems to be what's recommended for washing our hands prior to undertaking a procedure. But and wear gloves during the procedure. Just one thing I want to say here is that there are hospitals now in WA and Victoria that are mandating a sterile technique for an IV cannula. So it's probably something that we probably need to think about here in Australia and in New South Wales. I guess if I had my way, cannulation packs should probably contain sterile gloves and also a fenestrated drape with a sterile skin prep in it as well. So have it all in there, because the whole concept of having doing ANTT is you wash it down, but then you're not supposed to repalpate, the skin. I don't know. I can't do that. I mean, I don't know how. If it's not plump and you can't see it, most people need to palpate so they can direct their needle. So I think having like a fenestrated drape, washing it all down would be worthwhile. Insertion, flushing techniques using pre-filled syringes. Again, they're not a bad idea if you're going to go all sterile, because you can get them as a sterile pre-packaged component. And using appropriate securement and dressings is important, and we're going to be talking a little bit about that in a minute with Claire. So I guess in summary, what we've incorporated in our hospital is the 5 rights of vascular access. So the right trained clinician who's credentialed and has procedural load inserts the right device, so considering length of dwell and infusate quality, into the right vessel after undertaking vascular assessment for the right patient at the right time. And that also includes using the right antisepsis, the right stabilisation and the right securement. And that's it. Thank you.
Thanks, Evan. Okay, so what we're doing today is we're actually streaming today these lectures on the internet, and we'll be recording them, and then they will be posted at the Avatar website. So you'll be able to watch them again. So I'd just like to invite Claire back up to the lectern to do her second presentation on post-insertion care.
Thanks very much, Kay, and thanks, Evan, for that. So I've got 20 minutes to cover everything you need to know once the IV's in, and some my disclosures again. So obviously we talked about that cycle, decide on the device, insert the device, keep it functioning, and then remove it. And now that we know PIVs can be used beyond 72 hours, really our goal with PIVs is that if a patient is going to have a PIV, they just need one, but it needs to keep working. That's our problem. So Evan's very nicely already covered the insertion. So, and as with always the way, insertion gets the most focus when actually it's just that first time point in a long journey. So I'm going to talk about the function and removal strategies. So I mentioned earlier, PIVs, huge failure rates. We constantly see in our studies anywhere between 30 and 50% of PIVs have a complication and have to come out because of a complication. So I always think a nice way of remembering this is iPod, like the Apple device that maybe you have at home. So I for infection, P for phlebitis, O for occlusion. We usually put infiltration in there because it's quite difficult to know, to prove whether it's an occlusion or an infiltration a lot of the time. D for dislodgement. And of course, what is getting a lot of excitement and attention at the moment is people have finally decided that they're going to take an interest in bloodstream infections in peripheral cannulas instead of just central lines in ICU, which has been the clear focus over the years. But this is from 6,000 cannulas that we followed very carefully in 3 of our hospitals, and the actual catheter-related bloodstream infection rate was 0.017%. So of course it's devastating. Of course we don't want that to occur, but it is actually quite rare. Now obviously PIVs are not always investigated properly, so they don't always swab the tip if it is an infection. You can't often prove it. The 0.017% is proven infection. But even if we look at all bloodstream infections, so in our study we saw about 1 in 300 patients had any type of bloodstream infection with a PIV in place. But when we divided that into routine versus clinically indicated, it was actually the routinely replaced cannulas. So the patients that were on the 72-hour policy that had a 1 in 200 rate of bloodstream infections, and the people on clinically indicated had 1 in 400. Now, so they had less, which is counterintuitive to what some people would say. Although we would think that that's probably because you're puncturing their skin more often, you've got more chance of doing a poor procedure and putting bacteria in. Obviously, that's not statistically significant, but it doesn't give you any cause for concern. So what is our main problem with PIVs? Well, it's actually this. It's about 1 in 4 just stop working, So you draw up the antibiotic, you rush over to the bedside to give your antibiotic that's maybe already 10 minutes overdue or whatever, and you just find the whole thing's blocked and won't work for you. So that's really what we need to focus on. So I've got 4 strategies here I'm going to briefly talk about, bearing in mind that it would be great to talk for an hour on each of these and all the evidence, but I'll give it a go at least a few highlights of dressings and securement, connectors and how we keep them clean, flushing and diluting, and monitoring and removal. So dressings first, because that's my passion at the moment. So we don't really think about dressings a lot, but what do we actually want that little, 12-cent piece of polyurethane or whatever we're putting on to do? Well, of course, we want it to cover that hole that is in the person's skin and keep it clean. It'd be quite nice if it actually stopped the microbial regrowth at the site. We, of course, also would like it to stop the PIV falling out. We'd also like it to stop just that gentle, small movement that happens all the time as people move their hands or knock their cannula, where the inside of the vessel, the vein, is constantly being irritated and by that piece of foreign body in the vein. So we'd quite like it to keep that catheter very rock solid. We'd like it to be transparent so we can keep an eye what the site is doing. We'd like it to breathe, so sweaty patients, hot patients, we'd like the dressing to stay on but stay clean underneath. Some patients are oozy, right, and that's trouble keeping the dressings on, so if the dressing could somehow absorb the ooze or prevent it, that would be good. It needs to be easy. You need to be able to put it on easy, take it off easily. Hopefully people don't make mistakes with it easily. And of course we'd like it to be comfortable. We don't want the patient to have a skin injury or a reaction in any way or a skin tear. And lastly, we don't want to pay too much for them because we use so many of them. So I think over the years we haven't really thought a lot about PIV dressings, and now we're thinking more about Securemen as a separate issue. So we used to think the dressing could do all of that, just a little piece of see-through borderless polyurethane, but no surprises, it actually struggles to do all of that. So that was the ideal world. This is the real world. So this is what we see in our hospitals all the time, and I'm sure if I walked around your hospitals I might see a few of these too. So traditionally, because we have taken PIVs out after just a few days, or they stopped working after a couple of days, nurses aren't really in the mindset of doing dressings. We are in central lines, like we know we've got to do it weekly and we document that, but PIVs we kind of think, oh, it's going to come out anyway, so it's not really in our historical practice to do PIV dressings. And I think maybe that's why when we see dressings like this, we just ignore it, or we put a bit of extra tape on, don't we? A lot of tape, a lot of non-sterile tape, which actually usually falls off within 24 hours anyway. So it's a bit of a fix, but it doesn't generally last. So this, I do have some evidence for this. So, when we've done audits in our hospitals and just walked around, we've asked just three things. Is the dressing clean? Is it dry? And is it intact? And so we consistently find about 1 in 4 at any point in time of our dressings don't meet those criteria. And I mean, come on, this is basic nursing care. It's pretty easy, The other problem is, as someone alluded to, even though we have a policy that we use one particular type of dressing for PIVs, people are very creative and they go to the wounds cupboard and they take a bit of this and they take a bit of that. And we find often there's 7 or even 9 different types of dressing and tapes and all sorts of things in use. And of course we know, this is from our 6,000 patient cohort, that about 6% of PIVs fall out or become dislodged. So, if the dressings are not stopping them falling out, well, that is, obviously a problem with what we're using. So what do the guidelines say? The guidelines are now, just the last few years, starting to recognise that dressing is one thing, Securemen is another, and you can't really expect one product to do everything. So they all say that you need a sterile product. In Australia, I think we're pretty good at using a sterile product. Not everywhere in the world has that luxury. And most of them say that go for a transparent dressing, but noting that the actual evidence for transparent dressings versus, say, sterile gauze and tape, which is used in some parts of the world, is not actually very strong as to whether it makes a difference on patient outcomes. But they do say if your patient is sweaty or oozy, then use the gauze and tape while you have to, and replace that more often than you would a transparent. So Securemen, they're all now, the guidelines starting to say, don't forget Securemen. You have to have a method. You have to think of a way to keep your catheter in. But they also, I love this one because whatever we do, we can stuff it up, right? And so they say, make sure you don't impede the circulation when you do the Securemen, because we do see sometimes people just putting tape around the limb or bandaging, and the IV occludes because of that reason. So our old products traditionally is just the borderless piece of polyurethane, very cheap, see-through. In more recent years, most of the manufacturers are now reinforcing those dressings around the border. So we see like 1, 2, 3, 4 sides of the dressing will have increased adherent tape of some sort around the border. Now, again, not a lot of evidence about this. One review, this Cochrane review, did suggest that they may reduce accidental removal, having a simple transparent versus gauze. Boarded polyurethane, not many studies to date, but looks like there may be an effect on reducing dislodgement, but ironically increased phlebitis in one study, so difficult to say. But the evidence hasn't really kept up at all, because these are all the products that are coming through now. So manufacturers, of course, have started thinking, how can we get more Securemen into our dressings? And they're all doing that in different ways. So I mentioned the boarded dressings, and this is not meant to promote any particular product, just to say that here's a few items that are out there. The other option are these sutureless securement devices, so we all know those from PICs and CVCs, stat locks and grip locks and so on, but they are starting now to be used sometimes for PIVs as well. Another option is this newer one, which is starting to come into Australia, where they're trying to put securement and dressing into the same product. And of course, now we're seeing a lot of these antimicrobial dressings. We know that there's really good evidence that they do reduce bloodstream infections in central lines. We don't know that in PIVs, but I guess it stands to reason that if they're going to prevent microbial skin growth at one part of the body, they're going to do the same somewhere else. So again, if people are saying that they're keeping a 3-day removal because they're worried about infection, well, actually, maybe we should think about the infection risk rather than time, which has been shown not to work. There's a lot more of these low-cost options coming now. They've actually worked out how to put the chlorhexidine in the glue. So instead of an expensive-ish kind of biopatch, which people haven't usually wanted to spend that money for PIVs or the Tegaderm CHG, you'll see a whole range of the sort of transparent dressings with the chlorhexidine coming in them at a lower cost. So that's another new option. Now, we've tried to provide some evidence around this. We did a large trial with NHMRC, the government funding, recently, and we had about, a couple of thousand patients. So we looked at standard polyurethane, so no border. We looked at bordered polyurethane. We compared it to a sutureless securement device, and we also tried tissue adhesive, so the histoacryl dermabond kind of tissue adhesive that we have used for years in lots of wound care and lacerations, but is now starting to be tested and used in vascular access. So we had high hopes, and we would have been happy if any of these interventions showed a significant reduction, and we thought they might all. But unfortunately, we found very high rates of failure pretty much in every group. The lowest was in the tissue adhesive, but even that wasn't statistically different. So we were all a bit disappointed, but I guess it shows us we have to keep looking. So the interesting thing in this study is, and maybe what caused those results, was that nurses didn't just put any one of those dressings on and leave it at that. They were very ingenious and added many, many layers of all sorts of tapes, tubey grips, backboards. There was heaps of added securement. So and that's the real world. Like in research, you have to have this balance between testing things carefully, but also accepting that people are going to use them in the real world setting. So we didn't stop people doing things. And I think maybe that's why the groups ended up very similar, because of all this extra product that's used. So we're trying to dig through this data at the moment, and it does look that there is some suggestion that it is the use of all the extra things that makes the difference, not so much what the base product is. So I think a lot of those historical things that we've never tested and we don't use, or the tubey grip kind of things, the little stockingette kind of adjustments, perhaps we should look at that instead of just using micropore by the 8 kilometres of it per patient. Maybe we should stop and study that and work out how much, how often, or should we be using a better quality tape perhaps? I don't know. Now, we have a Cochrane review that we will update soon, and when we put in the data from all the randomised trials of tissue adhesive on PIVs, that is going to show a significant reduction. So putting all those trials together looks like there's about a 7% reduction in catheter failure in PIVs. So from 40% say to 33%. So that is an awful lot of PIVs that could be saved. But the problem, of course, with glue is it's very fiddly. You need someone who knows what they're doing to put it on, because you only need a very small amount. So you can't really just put it on the IV trolley and let all the RMOs and everybody have it, or you're going to have people stuck to the patients. And I don't, that's not a joke, like we have done that ourselves. It's also expensive at the moment, and there's too much in the applicators in Australia. Now the manufacturers are working on that. Again, we'll soon be seeing small applicators, lower price coming through. So it is coming. But if you have an IV team, for example, you can control, who's using it, then we do recommend that. So obviously that's not for a patient that's having a procedure, but for patients that are going to need their IV in for a few days, that you maybe at high risk, you don't want to lose the line, then we would recommend it. So I've got a video here of how you apply the glue. It's not very long. Hope you can see it. So I'm not sure this is working on the streaming, so I'll just... Oh, it is working. That's good. So you can see that the nurse is just applying literally one drop or 2 drops right into the insertion hole as well as under the hub. So tissue adhesive does have some antimicrobial properties, so it's quite likely that it's a good infection prevention as well as securement. And it probably also just provides a nice plug that holds the securement very firm. So if you remember, I was saying most of the dressing manufacturers have been increasing the security around the dressing, but it looks to us that probably we've missed the point of we have to reinforce securement also right at the insertion site and right under the hub. So how do you get it off is people's next question. So I've got another little video here. And this is a PIV that was only just placed, so the glue is as firm as it's ever going to get. It does tend to disintegrate after a few days. It's usually just a fine white powder. So bearing in mind this is the most you'd ever have to remove, and she's just using a adhesive remover, you know, those little pre-packaged wipes you can get, but you can also even use paraffin to take it off. We haven't seen any more skin tears or any more irritation than we see with standard transparent dressings anyway. So we've now moved on to our next randomised trial. This is what we're working on at the moment. We're looking at this combination securement dressing the Sorbeview shield. We're doing more work on the tissue adhesive to try and look through that. Now I better get off dressings, even though it's my hobby horse. Connectors. Now this is what I asked my husband for Christmas. I'd like a new piece of jewellery, and I'd like it to be like a charm bracelet instead of all those charms that people get from, what's that shop called? Where you... Exactly, that one. You know, I'd like one if anyone's got time on connectors, because it just amuses me how many there are, all the different colours, all the different shapes. I mean, how do you decide which one to use? Now, this is why we can't decide which one to use, because even the guidelines say there is no consensus on design. We know design can affect infection. The more internal surfaces, the more difficult the outside is to clean. Obviously, the more likely there's going to be bacteria hiding in there, but there's never been a trial to actually help us work out which one. So at the moment, we have to use our just common sense judgment. The other thing is that there is some suggestion connectors do prevent occlusion in central lines and PICs. Possibly that could be true in PIVs as well. That would be a big advantage, because remember, occlusion is our #1 problem in PIVs. But again, it's a controversial area because nobody's done the randomised trials to sort that out. So regardless of what connector you end up using, let's talk a little bit about how to keep them clean. So if you walk around your hospital and swabbed the connectors, as we did recently, you'd find about 50% of them will grow something. So this is before they're decontaminated. And what do they have on them? They've got bloody everything, really, like every sort of skin organism you can imagine, including Staph aureus, which of course is a very serious deadly bloodstream infection if that gets through the connector. We also found mouth organisms, lots of things that grow on the face and hands. And remember, this is just basic culturing. This isn't even using fancy microbial investigations, which probably would pick up a lot more microbes than, you know, the basic agar plate technique would pick up. So all the guidelines say we should disinfect the connectors before we access them to give an injection, but how do you do it? So this is, you know, this is just the sort of thing that keeps me awake at night, but this is a few of the guidelines, just all the different ways they recommend. So the CDC says you can use any of those sort of antiseptics, chlorhexidine, povidone iodine, alcohol. The SHE, which is the Hospital Epidemiology Society in America, says you should actually use the caps, the antiseptic caps that you keep on it all the time on the port. They don't even mention swabbing. EPIC 3, which is the NHS UK national guidelines, says 70% alcohol is what you should use, and they actually give a time. They say 15 seconds. Other guidelines say anything from 5 seconds to 60 seconds. IV Nursing New Zealand, they give us a few options, and they actually note that it's an unresolved issue because we haven't got the randomised trials to work it out. And just for a bit of fun, I put this one in, Association of the Anaesthetists of Great Britain and Ireland, who don't even mention decontamination of connectors in their vascular access national guidelines, and I wonder why that is. Okay, so we're trying to sort this out in some way. So at the moment, we've finished a study in the laboratory. Now, remembering that laboratory evidence is not directly applicable to clinical, but it's a place to start. So we've compared the alcohol wipes. How many people are using alcohol wipes, 70% alcohol as their standard? Still plenty, yep, plenty. And the chlorhexidine and alcohol, have people moved to that? Some people as well. Is it the same people? Because you're like having a go both ways. No, it was different. Okay. And what about the alcohol impregnated caps? Has anyone taken those on board, started to use those yet? No? Okay. No? You haven't seen them? You have seen? Oh, you have some there? Okay. Home TPN. Great. Yeah, they get quite popular in the States and coming here. So what we did was we put bacteria on the connectors, and we didn't put huge amounts. We put the sort of amount you would likely see in a hospital, and then we swabbed them either for 5 seconds, 15 seconds or 30 seconds. We used the alcohol, the 70% alcohol. Is that my phone? No, it's yours. Chlorhexidine in alcohol wipes, or the caps, the alcohol caps. And we looked at the percentage of microbes that were stopped from getting through the connector. So this is what would have got through into the blood. So it was very interesting to us. So the 70% alcohol wipes performed the worst, and as you increased the time of the disinfection, it increased the number of microbes removed. So that makes sense. The alcohol impregnated caps sat in the middle, but then when we went to the chlorhexidine and alcohol, we got a really strong and consistent lot of results that using those had a much higher rate of getting rid of the microbes, and the longer that we use them for, the better. But even 5 seconds, because bearing in mind that in reality we know that it's not very common for someone to spend 30 seconds cleaning a connector and then waiting for it to dry. If you kind of accept that 5 seconds might be as good as it gets, that still was in the very high 90%. So, we don't know if this means that the chlorhexidine will build up on the connectors over time. I mean, that's what it does on the skin. It has a residual effect. We don't know if it degrades the connectors over time. The plastic maybe. And we don't know if maybe it gets injected into the patient and if that's a problem. So, people are starting to use them. And you've got a comment? Yeah. Yeah, so she's bringing up very good reading. FDA, the US FDA has just put out a safety notice about chlorhexidine, reminding clinicians that that is a potential for allergy and anaphylaxis. And of course, people are using chlorhexidine now for bathing patients, for hand hygiene, for everything. So it's everywhere. Yeah, I mean, I think it's back to, of course, talking to the patient. Do they have an allergy? That's something we should be doing for everything. But I think given the amount of chlorhexidine we're using at the moment, we're not seeing a tsunami of complications. So it's something definitely to be aware of. But I'd be more concerned at the fact that we're using chlorhexidine so extensively that eventually we're going to get multi-resistant organisms, to that. But so if I can move on to flushing, because I'm probably nearly out of time. Flushing. So we recently did this survey through the Queensland Nursing Union, so it went to all the nursing members throughout Queensland, and we just asked them what they do for flushing in their practice and what their policy is. Now, it could not have been more random if it tried. There were people saying we never flush, people saying we flush every 2 hours, people saying we do 3 ml flush, 20 ml flush, we use heparin, we don't use heparin. It was so varied. So again, we're trying to push some evidence and to test this a bit more consistently. So we did a trial that we published last year, just a small trial, but we randomised patients to have a 3 ml flush as their routine or a 10 ml flush. Now, I would have thought that more flushing would be better, less failure, but actually we saw a bit of a suggestion that actually the larger volume flush was irritating the vein more. So these are the rates of catheter failure per 1,000 hours. So we saw 5 in the 3 ml group and 7 per 1,000 in the 10 ml group. Now that wasn't statistically significant, but it's a bit of a suggestion that it's something we should look into. We also randomised the routine flush to be either daily, which was actually our policy, or 6th hourly. And again, I thought more flushing is probably going to be better because that's what I did when I was young and, that must be right? But actually, very similar results. The more it was flushed, the rate was actually 7 versus 5 per 1,000 hours of failure. And that one was P.05. But when we looked at the data really deeply and looked at the factors that were significantly associated with failure, females were more at risk. That comes up in every study. Hand placement, again, comes up in most studies. But the interesting one was this number of accesses per day. So for every sort of 10% increase in the number of medications and flushes and things that were being given through the device, we saw a hazard ratio of 1.2. So like 120% the rate of failure the more it was used, which is kind of a worry because we put these things in to use them. That's what they're for. But if the using them is actually what's driving the vein to swell internally, to occlude, or to become dislodged because we're fiddling around with it more regularly, that's really something to think about. Now, maybe it's what we're putting through the devices, of course. Now, how we dilute our medications comes from those manuals now who wrote those? Did God write those? Did Noah? Are they based on randomized trials of 100 mils versus 50 mils over 30 minutes? No, they're based on good, physiological, theoretical evidence, usually from our pharmacy colleagues. And we're grateful to have them, but we've very rarely actually tested them. So this is from 1,000 patients with nearly 1,600 PIVs from up in Brisbane that we just finished. This is Nicole Marsh's study. And we looked at everything that happened to that PIV over the life of it. And I've just pulled out some of the infusions since we're talking about this. Now, Fluclox, which we would dilute 1 gram in 20 mils, we would give that as a push over 3 to 4 minutes. That tripled the risk of failure. And remember that the average risk of failure is 34%, say. That's a big risk factor. So those catheters were much more likely to fail from phlebitis or occlusion. So that suggests to me that Fluclox, dilution and injection process we're using, either nurses aren't following it, the 3 to 4 minutes is becoming 1 to 2 minutes, or maybe we need to go back. Maybe it needs to be in, 50 mils. Maybe it needs to be over 10 minutes. We need to work on that. Same with Flagyl, that doubled the rate of catheter failure from phlebitis. So again, we get those in those nice little bags and we run them over an hour, but it suggests to me that either they're not suitable for PIV or we need to do better at our dilution and delivery of those. Continuous infusions also significantly increase the risk of failure, and that fits in with this whole message that seems to be coming through of the more you squirt things under pressure at an internal vein wall, the more unhappy it gets. And similarly with continuous therapy, which is more use every day for different medications. 1 minute? Okay, that's good because I'm on the last one. So removal. So of course we want to get these PIVs out as soon as they're not needed anymore and as soon as there's any complication, but we don't need to take them out routinely. So, but the problem is people don't do this. Even now, under our 3-day removal policies, patients, about 1 in 5 PIVs, if you walk around any hospital, has not had any therapy for 24 hours, has no prescribed therapy, and should have come out. Nice study from Ireland where they asked patients, do you know why you have a PIV? And 40% of them said they had no idea. And they found that for those patients, there was 7 times the risk that the catheter was redundant. And that's probably because nobody else knew why they had an IV or even didn't know they had an IV. Now, we know that many of the guidelines have now already moved to clinically indicated replacement. In fact, 5 years ago, the major international infusion nursing standards of practice moved to that. The entire UK adult NHS system, it's now mandatory to do clinically indicated policies. But people are still often quite confused about what that means and still very worried about infections. Now, so I wanted to talk about removal. What doesn't work? Having these routine removal policies doesn't work. We have not seen any benefit in terms of reducing any sort of complication, regardless of whether it's phlebitis or bloodstream infections. And in fact, as I said, we had zero catheter-related bloodstream infections in our clinically indicated group. They had catheters in place for up to 3 weeks. And even when you looked at other things like phlebitis, the highest rates of phlebitis were actually in the first few days. And that fits in with some patients are just more sensitive to having a foreign body, and if they're going to be sensitive to it, that usually pops up in the first few days. So what we do know about routine replacement is it'll increase the number of skin penetrations. We've had many people bring that up already. And the problem is, in many people's mind, they see it as like a seat belt. They think, well, even if people forget to take the catheter out, if we have a 72-hour rule, it'll come out then. It'll sort of be a safety net. But unfortunately, I think that breeds this. We know it doesn't. I mean, there's many PIVs that are left in now. And I think it's a distraction. You know, if the problem is redundant catheters, let's think of interventions to target redundant catheters rather than relying on some other policy that's unrelated to try and save us. Similarly, if the infection risk is the poor dressings, which we know it is, poor decontamination, poor ANTT, or poor insertion, then we need to target what the actual problem is. This is a forest plot from the Cochrane Review. There's been 5 RCTs on this topic, over 10,000 patients randomised, same results, no effect. There's 2 large RCTs from China coming out, same results. Brazil has just finished another major randomised trial. They don't have their data yet, but we'll just have to wait and see. Now, the last thing that doesn't work, Kay, is, now I know this is a bit controversial, but I'm going to say it anyway. Daily monitoring and doing scores and even documenting it doesn't actually work at getting catheters out that should come out, because unfortunately people either don't do the assessment, or they do it but don't document it, or they document quite happily that the patient has a red painful catheter, but they don't act on it. And this is the biggest problem. It's a bit of it's lulling us into a false sense of security. So can anyone tell me how many PIV, like documentation scores or risk scores there are? How many tools and so on? Like the VIP score, have a guess. Lara? 6? Anybody? 7? Nobody knows. 71. There's 71 phlebitis tools. That's not even measuring occlusion or dislodgement or infection. 71 phlebitis tools in the literature. Now guess how many of them have been validated or had any validation work? 3, exactly. Thank you, Evan. You've read the paper, have you? So 3. So remembering that a tool needs to be validated. I mean, it might look like a good idea, it might look like the right sort of questions to ask, but unless someone actually goes through and tests it to see if it works, we can't trust it. So that is a big issue, and that's a paper where we publish that. We also know if you walk around the hospital, or in Evan's international study, 10% of PIVs at any one point in time are symptomatic. So they're painful, they're half falling out, they're red, they've got soiled dressings, it just goes on. So what we're doing at the moment is not working. So what do we need to do? Now, I can't tell you yet, but this is Dr. Gillian Ray Barrell has got a 2-year grant to work on this. She's going to trial a new decision-making tool. So it's called I Decide, and it's really trying to prompt people into not just doing an assessment, but to actually making a decision and documenting the decision about the action. So can't say it'll solve the world yet, but we hope it will be better than what we have now. And it's really going through the things we want to know is, does it work? Like, is that catheter still working? Is it still needed? Can we get it out? Is there any hint of infection? Of course, take it out. Is the dressing and Securemen adequate? If not, fix it up. And of course, educating the patient. Like, if you feel this, if it's painful, let us know. If the dressing becomes loose, ask your nurse to fix it. Ask your doctor, can it come out? So I hope that will help in the future. Maybe next year, the year after, we'll have some data, and maybe some of you would like to help trial these sort of tools, because these are the things that we can't do alone. We have to do that with people that are working with patients and can help to see what would work practically in the clinical setting. So thank you.
Okay, some more group work now. Over to the second lot of group work, which is about how can we address the issues that... Oh, why doesn't it want to go to the next slide? Anyway. All right, you've got the instructions anyway. So thinking about the patient that you, or the problems that you had in the first lot of group work, just work quietly for a couple of